Now, this is again the evolution of the diagnostic criteria. So, if we talk about the NIH criteria in 1990, they took only hyperandrogenism and the anovulatory cycles of ovulation into the criteria for defining PCOS. However, when we talk about ASHRAE, and we talk now, which was widely followed, the extended ASHRAE ASRM criteria, they are taking into picture three features, of which one is hyperandrogenism, one is ovulatory dysfunction, and the other is polycystic ovarian morphology. So they both say that two of the three criteria are fulfilled, then only a patient is labeled as polycystic ovarian syndrome. So this is something which we as doctors have to educate our patients, because there are so many myths in the minds of people that why only if there is hyperandrogenism they think that's PCOS, or if there is irregular periods they think it's PCOS, or just a scan showing a PCOM morphology they think it's PCOS. So a criteria to first define PCOS is very important, and these are the two main criteria which are currently followed. Now, the other important thing from a point of view of a doctor or a gynecologist is that we need to define the various phenotypes we get in PCOS. The first important question arises in the minds of people is that PCOS is, the patient has to be obese. No, it's not like that. It is common. Around 60 to 80% of women suffering from PCOS suffer from obesity as well, but they are not synonymous. It does not mean that each of them, they both are independent factors. So we need to understand the phenotypes, and we need to classify the phenotype, typically the type of PCOS the patient is suffering from. So a word about the phenotypes of PCOS, because this is something which is important for terms of treatment as well. Now, in 2016, the ASRM, they came up with the criteria and the prevalence and phenotypes of polycystic ovarian syndrome, which kind of divided it into four basic phenotypes. The first type 1 and 2 are the classical PCOS. So a classical PCOS will have a particular picture, like it will have, as in the table shown here, it simply shows here that it will have, hyperandrogenism, it will have ovarian dysfunction, it will also have polycystic ovarian morphology. However, in the phenotype B, that is also a classical type of PCOS, but it will have only two features, that is hyperandrogenism and ovulatory dysfunction, and the ultrasonographic picture is missing. So these form the basic. The core PCOS comes from this. So like you can say 80% of PCOS are into this, and the rest 20% come into ovulatory and the normoandrogenic PCOS, or the phenotype C and D respectively. So we'll be talking about them further. Now, A, as it is the most common and the most severe form of PCOS, and it is characterized by definitely abdominal obesity, increased androgen, and it is representing almost 60% of PCOS. Then B, it is very much similar to type A, because it's again a classical PCOS. It will also have hyperandrogenism and ovulatory dysfunction. And you find the main difference here is that there are higher LH levels and LH-FSH ratio. So both these pictures, A and B, you can see that it's quite common when we think about PCOS, right? So the classical PCOS is more common. Coming to the non-classical. The non-classical is formed by phenotype C and D. So the phenotype C is ovulatory PCOS. So this table here is a very good table to remember. Like phenotype A is point number 1, 2, and 3 all are present. In phenotype B, only point 1 and 2 are present. In phenotype C, as it is ovulatory dysfunction is absent. So that's why it's called as ovulatory PCOS. The patient is ovulating regularly. So it is only hyperandrogenism and polycystic ovarian morphology. Last is the normoandrogenic. So here there will be no features of hyperandrogenism. However, there will be ovulatory dysfunction and polycystic ovarian morphology. So you would see that in all these phenotypes, they have followed at least two criteria are definitely present. So you can say that the classical is definitely more common. However, the non-classical one, that is the type C and the type D, are less common than the classical ones, and hence they're difficult to diagnose. Because if a patient is coming to you with ovulatory PCOS, you will not suspect, because the ovulatory cycles are regular. So that's why the criteria came, and that's why any of the two criteria is fulfilled, whether she is ovulatory or whether she is normoandrogenic. But if she has the other two features, she'll be PCOS. So these phenotypes have clarified our myths about the classical and the non-classical PCOS, and have helped us to define PCOS phenotypes in a more better way. Now we talk about the clinical features. So there is a range of clinical features that come into picture. You see that there is reproductive health involved in the terms of irregular periods, anovulation, polycystic ovarian morphology, hyperandrogenism, subfertility. Coming to the metabolic aspects, the metabolic aspects are different. So this PCOS is a mixture of reproductive, metabolic, and psychological features. When you talk about the metabolic features, it is definitely insulin resistance takes a toll, obesity, dyslipidemia, pre-diabetic status, GDM in the pregnancy, diabetes, cardiovascular risks, which is very much common nowadays. Coming to the psychological aspects, this is one of the aspects of PCOS which is actually talked very little. So taking 1 minute of your time here to talk about the psychological aspect, because this is something which is more common in the adolescent population, and these girls are very fragile in terms of how their body looks, how they are feeling in terms of their sexual health, and if they're obese. So it all affects them psychologically. So depression and anxiety are one of the major factors that affect these young ladies, and it kind of takes a toll on their mental health. So they have a negative body issue, they have low self-esteem, there can be poor quality of life. So as a whole, PCOS can represent with any of these clinical features, but for the criteria to diagnose, we should have those three, and out of those three, any of two should be satisfied. This actually understanding the pathogenesis of PCOS is again important, because many of the protocols which we follow for the stimulation of the for the egg stimulation or the ovarian stimulation in PCOS women, whether that's ovulation induction or whether that is in an IUI protocol, or whether it's an in vitro fertilization or a Dixie protocol. So the pathogenesis of the PCOS helps us to understand where to hit, where to target our the ovulogens or the gonadotropins, and what kind of gonadotropins or a protocol to be used. So just understand it, so that while we talk about which antagonist protocol to be used or why gonadotropins as an FSH to be used, you get to understand why we are using those. So to understand these, we need to know the pathogenesis. So this is just a brief picture, like you have the pathogenesis, what all is there. There is definitely neuroendocrine dysfunction at the level of the brain, there's ovarian dysfunction, then the adrenals are affected. There's a whole concept of insulin resistance being a part or the cause of PCOS. And lastly, adiposity. So this also is a cause. Obesity as a cause of PCOS is also known, and vice versa, PCOS leads to obesity also. So talking about the neuroendocrine dysfunction first, we all know that in PCOS there's increased gonadotropin releasing hormone, which is released from the hypothalamus, and it is more sensitive towards LH secretion rather than the FSH. So the first thing that we talk about, LH FSH ratio, we see in the our blood test, people are still giving it. And although it's not in the criteria though, so that excessive LH and that ratio of LH to FSH LH being more than twice the FSH is because of these following reasons. Now, the increased GnRH from the hypothalamus causes increased neurons and connectivity, and there is altered kisspeptin secretion, as a result of which there is excessive LH secretion, which is relative to FSH. So LH being higher and the FSH being lower. Just a second. And there's ineffective suppression of the LH pulse frequency by estradiol and progesterone due to the reduced sensitivity of neurons to negative feedback. Then this leads to androgen excess and increasing LH by blocking the hypothalamic inhibitory feedback of the progesterone, and hence it causes hyperinsulinemia. We also know that the LH hypersecretion both basally and responds to the GnRH, as it is seen here. It is the characteristic hallmark of PCOS. Okay. So this leads to a big debate whether the hypothalamic defect is primary or is it secondary. So primary means that it happens intrinsically at the level of the hypothalamus, or is it as in a negative feedback from the ovaries, because next we are going to talk about the ovarian dysfunction too. What does decreased FSH lead to? So we all know that FSH is very important for the follicular growth, and an increase in the GnRH pulse frequency, which is more sensitive or more pro towards LH, leads to a decreased FSH in comparison to LH. And this negative feedback affects chronically elevated estrone concentration, thus leading to peripheral aromatization of the increased androstenedione. Modestly increased levels of inhibin B are there, which are derived from the small follicles. These all lead to an increased LH and an FSH ratio, which is actually causing what? It is causing impaired follicular development, also leading to hyperandrogenism. Coming to the ovarian dysfunction now. So in ovarian dysfunction, what happens? We know that there's an excessive response to rate limiting step of the androgenesis, you see. So there's the increased, synthesis of 17 alpha hydroxylase enzyme, and also the 3 beta hydroxy HSD enzyme, which leads to increased production of androgens in the granulosa cells. So in the ovaries, there's excess production of the androgens. Now, what these androgens do? So as there is increased androgenic environment in the ovaries, it kind of suppresses the estrogen production, right? And this leads to the disruption of the follicle growth. It leads to, you can say, disruption. There'll be an abnormal follicular development. Third, we talked about was the adrenocortical dysfunction. As in the ovary, the same enzymes are exaggerated in the adrenals as well, and there's an excess production of adrenal hormones in the form of androgens again. So here comes the role of 7-hydroxylase enzyme again, which leads to excess production of the androgens. But it should be very clear that primarily it is the ovary which is the main focus of androgen production, and the adrenals are contributing just 25%. All these, we were talking about the follicular genesis. So androgenic environment in the ovary is bad for the follicular growth. So the beginning of follicular recruitment is very intrinsic to the process of, the follicle development, because it is independent of gonadotropins. So abnormal follicular genesis occurs when there is high androgen production in the ovaries. There's a beautiful diagram which we'll just be seeing, okay? So this is a very important diagram which actually shows us that what happens in normal follicular genesis and what happens in a PCOS, which we term as an abnormal follicular genesis. So just remember this, because this is going to help you to understand how to stimulate the ovary, right? So we know that in a normal cycle, you have increased production of certain growth factors and BMP9 at the time of recruitment, and we definitely know that the preantral follicle, the part of the preantral to the antral phase, is independent of gonadotropin response. So it is governed by androgens, right? However, the later part where the preantral follicle forms and it goes to the antral follicle and forming a dominant follicle, this part is dependent upon FSH. In this part, normally the FSH keep on rising and the AMH stops, it keeps on falling. So we know that the FSH is leading to the dominant follicle development, and the AMH has to fall subsequently so that the one dominant follicle forms. So this is a normal ovarian cycle, okay? However, what happens in PCOS is there are multiple follicles. We all know that there are more than 20 of 19 follicles which say are periphery arranged, and they are less than 10 mm. They don't reach the dominant follicle state. So why does that happen? This happens because there is increased androgen production. As we know, how is that happening? Because of the impaired the synthesis of androgens in the ovary. Second, there's decreased the BMP9 also decreases, and the GDF9 also falls. So these growth factors also fall, as a result of which the androgens lead to excessive growth. So all the follicles, they start growing. As we know, the first part is independent of FSH. Now we also know there's deficiency of FSH and the LH is higher. So there is less chances that the FSH is going to take one of the dominant follicles or recruit it into select a follicle and recruit it into a dominant follicle. As a result of which, that is the reason why we don't get a dominant follicle. There's anovulation in PCOS. This is kind of exaggerated by the increased AMH which we see in polycystic ovarian syndrome. So the decreasing in FSH and increasing in AMH plus increase in LH also leads to reduced FSH responsiveness, and hence the increased LH leads to premature luteinization. So premature luteinization means that normally in these follicles, at once the size is acquired as 5 mm, they kind of acquire the LH receptor and they start getting luteinized because the LH is so much higher in the body. And since LH has also risen, FSH has, it's lesser in quantity, AMH is still kept high, the follicle is unable to recruit into a DF, and unfortunately, there's a follicular arrest. So all these things, hyperandrogenism, hyperinsulinemia, LH to FSH altered ratio, AMH being too high, lead to decreased responsiveness of the follicles to the FSH, the antral follicles, and there is arrest of the follicles, before they could be recruited to a dominant follicle. So that is the reason for anovulation. So this was important to be understood before understanding the concepts of how to stimulate in the polycystic ovarian patient, and why, what hormone we have to give, and why do we have to give FSH. So this is the basic concept, that there's deficiency of this. That's the reason we have to give FSH from outside. Subsequently, once we start about the the follicular wave theory, we'll be understanding how that helps us. So there's a stockpiling effect. This is a term which you should understand. There's a stockpiling effect, means that small follicles get piled up in the ovary, and there is follicular arrest. And this happen, the follicles of the polycystic ovaries, they grow very slowly, creating a stockpiling effect, and this growth might be mediated by deficient growth signals, as we saw the BMP9 was deficient from the oocyte, or the inhibitory effect of the excess AMH as well. Now, this is the picture which actually forms. So, stockpiling effect. You could see what is happening intrinsically is shown on an ultrasound. You get to see so many follicles which are less than 10 mm in size, and you don't see a DF. You don't see a dominant follicle because of the, abnormal follicular genesis. Now, we talked about a term called as premature luteinization. So we know that the granulosa cells of the antral follicles, in these women, they acquire LH receptors prematurely. So this is again very important. They get it at the diameter of 5 mm itself. So these receptors acquisition of granulosa cells seem to switch the follicle from proliferative to differentiation, and hence there's again a suppression of granulosa cell growth, or there's follicular arrest, and therefore they don't grow, or they don't develop into a dominant follicle. Now, this is again the same repetition to understand why there is anovulation. This can be overcome by increased FSH dose. When the granulosa cells are exposed to high amounts of FSH, their richness in the FSH receptor causes them to respond in terms of the estrogen production, and the protective effect of AMH is lost. And there is a reason why, again, OHSS happens in PCOS patients, because there is so many follicles that grow in response to FSH, and there is an abrupt increase in the E2 production, which is a predictive factor for OHSS if it's beyond 3000 or 4000. Now, talking about the management. So our the prior slides were basically for the students to understand that why in PCOS we are using different protocols, and what is the basic pathology, where do we have to hit, and why do we have to hit there, why do we want to give ovulogens, or why do we want to give gonadotropins, and then which protocol to be used to prevent from OHSS. So this was the basic pathogenesis. Now we're going to talk about how do we manage it. So there comes the role of management. We all know the first line will always be lifestyle management. The second, when we talk about ovulation induction, it has to be the first line by letrozole, followed by clomiphene and gonadotropins. Then we talk about the second line of management. If ovulation induction doesn't work, it's either laparoscopic ovarian drilling or gonadotropins. Lastly, assisted reproductive technology come as the third line of management of PCOS. So it's never the first line until unless there are certain factors which we're subsequently going to talk. So ART, whether IVF or ICSI in PCOS. So when to do, why to do, and why not, we succeeded in ovulation induction, or why not we succeeded with gonadotropin. So we'll be talking about the causes, why would we need ART in PCOS. So indications are that it is definitely not the first line until and unless there's an accompanying factor, like tubal factor, like a male factor, or so then in these cases, the IVF in PCOS can be considered as the first line of management, right? However, in 50% of the subjects, there is no other factor. So you have to proceed in a stepwise manner. So second could be failure of gonadotropin therapy or failure of laparoscopic ovarian drilling. Third, if there is a previous history of previous 3 IUIs which have failed, she has not conceived with at least 3 failed IUIs, so she has to go for an IVF next. High response, fourth, high response to FSH. So if there are more than equal to 4 follicles despite a low dose gonadotropin using an ovulation induction cycle, so definitely this means that she's over responsive. So in that thing, you'll have to you cannot, because the criteria for an IUI or an ovulation induction is a monofollicular growth. You don't expect multiple follicles growing. So definitely this might be an ideal candidate for IVF, or later on you might be converting an IUI to an IVF cycle. Lastly, luteinized unruptured follicles, which is quite common in PCOS women. And if that is happening, again, you can't help. You can't do IUIs, you can't proceed with ovulation induction. I mean, you see it subsequently while you're proceeding, and she becomes another ideal candidate for IVF in PCOS. So what is the prevalence of IVF in PCOS women? It's almost 33% of women attending for IVF. You see that they are suspected to have PCOS. So it could be irrespective, they're taking it for the first time, or it could be irrespective of they have taken what treatment in the past. And if you see PCOS, how many of them convert into IVF? Around 20 to 30%. So to understand the IVF in PCOS, we have divided the process into 3 parts. The first is before IVF stimulation, what all we need to do, how do we need to understand that we are going to follow this woman in this particular format or this ovarian stimulation regime. Second, how do we start the ovarian stimulation, and during the ovarian stimulation, what all we are doing. And then after the stimulation of an IVF patient, what is to be done. So, as it is suggesting that before we have to predict the response of a woman. So, if a patient has come to us, she's decided to be going for an IVF. Now, for her being a PCOS, first we need to predict the response. So, we know that AMH, that is the number one. First is AMH, anti-mullerian hormone, is used as a predictor of controlled ovarian stimulation in IVF for these patients. So, if you see, there's a study which has come up in the research which has shown that there is an advantage of antral follicular count as well as anti-mullerian hormone being very good predictors of the number of oocytes retrieved and the stimulation response. They also help you to guide the protocol and the treatments decisions to be taken. And it could also, it's very easy to get it, reproduced from the laboratories. And antral follicular count, on the other hand, is very good. If the person, the doctor who himself is or herself is stimulating the patient, gets an idea of the number. So the anti-mullerian hormone and antral follicular count, they form a basic predictors for the response, the ovarian response of a woman, which is we are taking for IVF. Again, another study where the AMH was assessed and it was used to be seen as a prognostic indicator for in vitro fertilization. Now, this is a very important table. Majority of us, we are using it in our clinical practice quite often. We know that a woman who has been having a normal AMH is approximately in the range of 1.5 to 4 nanogram per ml. And if it is higher than the 4 nanogram per ml, we often consider as a predicted response to the PCOS. And we consider her as to be a hyper responder. Low normal is considered 1 to 1.5 nanogram per ml, and a low is considered 0.5 to 1 nanogram per ml, and very low is less than 0.5 nanogram per ml. So low to very low are probably under the poor responders, and the normal form, the normal responders, and high is definitely the hyper responders. So AMH is here being used as a predictive value for the IVF stimulation response. Now there have been studies, even the committee of ASRM, which had published the OHSS committee opinion, they had said in that the AMH of greater than 3.9 gram per ml predicts hyper response in a very positive way, and it could be used as a marker to assess whether there is a higher risk of OHSS. So we all have discussed this, that AMH can be used for guiding the ovarian response, for deciding the stimulation protocol in the form of even gonadotropin doses, and also subsequently adjusting the or individualizing the gonadotropin dose during the stimulation as well. Coming to the second part, that is the age. So we know that the fecundity and pregnancy rates decline with maternal age in natural and stimulated ovarian cycle, and it is the best surrogate marker for oocyte quality is age. And in women past age 40 years, quantity does not make up for the quality, and this is very obvious. So it is not only for poor responders, it also comes into picture for polycystic ovarian syndrome patients. So by contrast, if we see that the young women with a limited ovarian reserve, they have good success rates despite their limited cohort of eggs. So good quality and high potential oocytes. Now, this is a diagram which we all know that the age limit is 35, and we see that after 30 years, here you see it is declining. So it has started to fall after birth only, and at beyond 35, it's fast drastically. The ASHRAE guidelines for ovarian stimulation. This was a big guidelines which were published by the ASHRAE, and a lot of my the PowerPoint data will be quoted from these guidelines. So they came on for ovarian stimulation for IVF and ICSI in case of normal responders, hyper-responders, and hyper-responders. And we've already seen that PCOS comes under hyper-responders. So they had said that for predicting high and low response to controlled ovarian stimulation, use of either antral follicular count or anti-mullerian hormone is recommended over ovarian reserve tests like, you used to do FSH, estradiol, inhibin B. So there's a strong recommendation that you should follow, either of these two, AFC or anti-mullerian hormone. And there is a conditional evidence that AFC and AMH both have a high accuracy in the prediction of an ovarian response. So also, they say that age also has some predictive value. However, assessment of expected ovarian response by age alone is not sufficiently reliable. Coming to the third aspect of predicting an ovarian response is the basal metabolic index. So, the BMI is basically, we have to see the weight as a whole along with the height. The ratio has to be assessed. Not just the weight of the patient is important. It is the BMI, which is the new, criteria which we are following for obesity. Now, the body mass index, basically it says that because weight loss in PCOS has a positive effect on the hormonal, metabolic, and the clinical parameters, and there are many recent studies which were subsequently I'm going to talk about, which has seen that BMI during the IVF cycles in PCOS patients actually affects their results. So this is a Turkish study which was published in 2016, and it was a retrospective cohort study where they studied 653, like a big number of PCOS women following the Rotterdam criteria, and they were all under the age of 40 years. They then finally considered two aspects, BMI as well as the age, to assess the response of the IVF in these PCOS women. And how did they assess that? They actually took out the clinical pregnancy rates. So as you see here in the diagram, in the table, that the women who had lesser age, who had 35 years less age, and they were normal weight. So, in the normal weight, or even they were overweight, in them, the clinical pregnancies were almost similar. However, if they were obese, the BMI was higher than 30, then it was 35.5%. Similarly, they saw the effect of age too. They saw that if the woman's age is greater than or equal to 35, and if she's normal weight, still there is a fall in the clinical pregnancy rates. So here it is 42%, so it will be 34% here. So there, even if the the weights of both these women are normal, even the age is lesser, then the ones with a lesser age group will have a good pregnancy rate as compared to those who have more than 35 years. So this actually showed us the effects of age as well as the BMI on the ovulation induction the controlled ovarian stimulation outcomes in the form of clinical pregnancy rates in PCOS women undergoing IVF. Second aspect of after the prediction of response, we have taken the age, the AMH, the AFC, as well as the BMI of the patient. Next, we see, is there any role of preliminary suppressive therapies like oral contraceptive pills prior to IVF stimulation? So basically, what does an OCP does? OCP does is it kind of reduces the GnRH secretion from the brain level, decreases the LHS of FSH secretion, and hence the intra-ovarian androgens, they fall. It normalizes the LH-FSH ratio. Okay. So the ASHRAE guidelines again recommend that there is a strong evidence which states that the combined oral contraceptive pills not recommended in an antagonist cycle or a protocol which is used for polycystic ovarian stimulation patients because of its reduced efficacy. So also there is a conditional evidence which states that whether estrogen or progesterone is to be used before ovarian stimulation for improving the efficacy or the the response of ovarian stimulation. So it is also not indicated. Now we come to the controlled ovarian stimulation. We have done the predictive response of the patient who is undergoing an IVF cycle, and we have not given her the therapies for suppression for a good efficacious stimulation as per the ASHRAE guidelines. Next, what to have to do? We have to follow certain principles of ovarian stimulation, controlled ovarian stimulation in IVF and ICSI in PCOS women. Now, we have to maintain these three things at least, that there has to be a GnRH antagonist protocol, there has to be a single embryo transfer, and there has to be a electrophoresis for all embryos. Now, the stimulation protocol. ASHRAE clearly recommends the use, they clearly recommends that prior to starting any IVF or ICSI therapy, the patient needs to be counseled that on the availability, cost, and convenience, increased risk of ovarian hyperstimulation, and also the options to reduce the risk of hyperstimulation. So the counseling has come in an important aspect of a controlled ovarian stimulation as per the ASHRAE, that is the International Guidelines for Ovarian Stimulation. Now, which protocol? So the controlled ovarian stimulation protocol that has to be followed is the flexible GnRH antagonist protocol. Though there was a study which was, there was a beautiful RCT that was done in 2010 in human reproduction, and they had compared the flexible GnRH antag protocol with a long agonist protocol. So what they had divided into two groups, 110 in either of the two groups, and they did a randomized trial in these polycystic ovarian patients who were undergoing IVF. So what they concluded was that the rate of OHSS was lesser, the dose of gonadotropins required in the antag group was lesser, and the oocyte number that was retrieved was almost similar, and the total dose of gonadotropins, that is FSH here, was lesser. However, there was significantly no difference in the achievement of pregnancy rates, that is the clinical pregnancy rates. So the ASHRAE Guidelines 2020 for the ovarian stimulation in hyper responders considers that the GnRH antagonist protocol is the ideal protocol. It is it's the best protocol, recommended protocol in regards to safety as well as efficacy. So this is the strong recommendation which is there from the ASHRAE as well. So nowadays, the fertility specialists are no longer continuing using the long agonist protocol, the antag. It's the time of antag protocol. However, they also state that if agonists are being used, it's always ideal that you should go ahead to a long agonist protocol over a short and an ultra short agonist protocol. Even the 2018 PCOS evidence-based guidelines, which was published by a combination of four societies, that is Monash, ASLM, ASHRAE, and Crescent in PCOS. So they also considered the GnRH antagonist protocol to be a preferred protocol for PCOS patients who are undergoing IVF ICSI cycles. To understand why an antag protocol is used, it is very important to know that this is because there is a rapid gonadotropin suppression and it leads to shorter duration of treatment. There is earlier follicular growth and there is higher E2 during the FSH stimulation compared to an agonist, which is very true. Again, if you're using an antagonist protocol, you can use an agonist for GnRH agonist as a trigger and hence prevent the risk of OHSS. And as a whole, also, if you see that the risk of OHSS falls quite considerably if you're using a GnRH antagonist protocol. So these are the reasons why it's considered more safer and equal efficacious as compared to the long agonist protocol, and why all the major societies have considered as this as a strong recommendations for its use in PCOS women undergoing IVF. Second, which gonadotropin to be used? So there's a big question mark whether to use minotropins, whether to use the follicle stimulating hormone, or whether to use the luteinizing hormone alone. So to clear the doubts, first we need to understand, as we already know, that there's an LH-FSH ratio imbalance, that the LH is higher, the FSH is lower. So we need to understand what happens in the normal spontaneous menstrual cycle. We know that one of there's a the concept of an FSH window and a threshold. So what happens is, at a particular level, when the follicle starts recruiting, it acquires a set level of FSH concentration, and that threshold is crossed and a window is created where the follicle starts recruiting, and there's a selection and there's a dominance. So this happens in a normal spontaneous menstrual cycle. But what happens in a stimulated cycle? We are giving exogenous FSH. And why are we giving? We know because the FSH is low in PCOS women, and the sensitiveness of the granulosa cells is also low to FSH. The receptors are less, and hence we're giving the exogenous FSH from outside. So what we do is we give exogenous FSH to recruit these follicles so that we get dominant follicles, okay, and the follicular atresia of those large number of follicles that was happening in PCOS women is prevented. So once we give this exogenous FSH, we kind of we are giving it again and again, and we are increasing the window of FSH. We are also causing a repeat thresholds. So we're getting more follicular getting recruited, and hence there's a larger number of follicles that starts growing. Okay, so this is to be understood to what happens in a stimulated cycle, why all the follicles start growing, right? So the ASHRAE guidelines, they say that urinary or recombinant FSH follicle stimulating hormone can be used in women with PCOS undergoing controlled ovarian stimulation for IVF efficacy with insufficient evidence to recommend a specific FSH preparation. So they're not biased towards urinary or the recombinant follicle stimulating hormone, although we definitely know that the urinary preparations are more likely to have batch to batch variations, and we will not allow them into our clinical practice by using in IVF stimulations. So they also recommend that exogenous recombinant LH luteinizing hormone treatment should not be routinely used in combination with the FSH therapy in women undergoing PCOS. Third question arises, like, is there a standard protocol of gonadotropins that has to be followed, or is there any individualized approach we should go for? So definitely there is no concept of a standard, gonadotropins. Why? Because no patient is similar. It has to be individualized, because we are taking into consideration an individual's AMH, AFC, BMI, age, all these 4 parameters with her previous history, with her previous stimulation in the past, previous IVFs in the past, what all response she has to ovarian stimulation. So the dose of the gonadotropin has to be individualized. It can never be a standard gonadotropin that has to be followed. How to monitor? Now, during the ovarian stimulation, you also have to monitor. You have to monitor with the help of an ultrasound or with the help of endocrine parameters. So what are the available ultrasound monitorings we have? We have antral follicular count, we have endometrial, thickness, ovarian volume, the Doppler, and in the lab monitoring, we have estradiol, LH, progesterone, and testosterone. So there are so many which are recommended, but do you know actually what is being followed, and do you know what is exactly being recommended by the international guidelines? It simply says that the addition of estradiol measurements to your ultrasound monitoring is probably not recommended, and majority of us are not using it. If we know there's a individual variation, there's a person to person variation in terms of the scan findings, which can happen in centers where people are being taught with the fellows. So then, yeah, estradiol measurements can help you guide better. Okay, the addition of a hormonal panel consisting of a combination of estradiol, progesterone, and LH measurements to ultrasound monitoring is probably not recommended. Although it is a poor evidence, but it still is not recommended. The guideline group suggests performing a single measurement of endometrium lining during the ultrasound assessment on the day of triggering or on the day of oocyte pickup to counsel the patients on the potential of lower pregnancy chances. So even also not to monitor the an endometrial thickness every time the patient has come to you for stimulation, follow-up or the follicular monitoring, because the patients probably of PCOS are going to have a freeze-all cycle. So it's definitely recommended to do it at the time of trigger or at the time of oocyte pickup. The ASHRAE 2019 PCOS guidelines, they actually say what is a high ovarian response in a hyperresponder on a PCOS woman. It is defined as an exaggerated response to a conventional ovarian stimulation, that is 150 to 225 international units of FSH, or if there is more than 19 follicles greater than 11 mm in the size on the day of oocyte maturation trigger. So this table is very important because this is going to guide you very well, like how to prevent OHSS and like which patient can go into OHSS. You have it in the back of your mind. You can counsel the couple. You can do preventive strategies for that. And or if there are 20 oocytes collected after the pickup, and that also increases the chances of an OHSS. Coming to the fourth aspect, like adjuvants which are being used in controlled ovarian stimulation, there are so many a number of adjuvants which are there in the market. We're using metformin, we're using myoinositol, and when we're using even combination of metformin and myoinositol. So like, what is exactly the evidence behind to its use in controlled ovarian stimulation? So we talk about metformin first. We know that it is an insulin signaling transition pathways there, and there is the insulin resistance which is there in women with PCOS. So metformin helps in stimulating the IP3 kinase, which is the second messenger. It helps in, the taking in the glucose uptake into the cell, okay, by enhancing the translocation of GLUT4 receptors onto the cell membrane. So this is how the metformin is helping in decreasing the insulin resistance. So it's basically insulin sensitizers, and there are n number of trials which are there in the research which kind of prove that polycystic ovarian syndrome patients undergoing IVF, why they are using metformin. Okay, so we'll be talking about these few. So like, there was a study in 2011 which kind of stated that metformin could be exerting an impact on the ovarian response by two mechanisms. That is, one by decreasing the follicular number and also by decreasing the E2 concentration, and hence it lowers the risk of OHSS. So here we are using metformin in ovarian stimulation protocols for IVF, controlled ovarian stimulation protocol, to decrease the risk of OHSS. So here the main aim is to decrease the risk of OHSS, as is seen here, that it reduces the expression of VEGF and it reduces the androgen mediated stimulation of early stages of follicular growth, thus lowering the E2 concentration, again decreasing the risk of OHSS. So this is how it helps us. The 2019 ASHRAE guidelines on PCOS, they give a strong recommendation that the routine use of adjuvant metformin before or during controlled ovarian stimulation in a gonadotropin agonist antagonist protocol is not recommended. So mind it, it is the antagonist protocol, it is not recommended, because we are not needing it. We are not suspecting to have a OHSS in an antagonist protocol. It is again a preventive strategy. So it recommends that if a woman is using agonist protocol, for that matter, they can go ahead and use a metformin before and during the controlled ovarian stimulation. So they state that there is a clinical consensus recommendation that an agonist protocol with an adjunct metformin therapy in women with PCOS undergoing Ivf treatment, following can be considered. It could be commenced at the start of the GnRH agonist therapy. It can be in between a dose of 1000 to 2550 milligram per day. Metformin cessation at the time of pregnancy test or menses, unless the metformin therapy is otherwise indicated, like probably she is a case of pre-diabetes or she is a case of diabetes. Lastly, metformin side effects should be noted and reported. The committee opinion of ASRM also states metformin to be used as a strong evidence on the use of metformin for decreasing the risk of OHSS in PCOS patients. So this is also true for the GnRH agonist protocols. Coming to the second adjuvant we know of, it's myoinositol. So we all know this is something which is widely being used by all the gynecologists, fertility specialists, for PCOS women to increase the insulin sensitivity and also balance the androgen hormones and improve the period regularity of these women. So what's its role in IVF? It says so. The myoinositol, it's basically these committee opinion, the international evidence-based guidelines for PCOS, which I was talking about, 2018. They say that it is still an experimental therapy and with the major evidence on the efficacy highlighting its need, and hence there's more need for the research. So they still consider it as an experimental therapy. Talking about the third adjuvant is aspirin. So aspirin we know was being used as a prevention of OHSS. So now the recent guidelines for ovarian stimulation for Ivf in PCOS or hyper responders, it says that the use of aspirin before or during the ovarian stimulation is strongly not recommended in IVF population, and especially for poor responders. The once we've done the now we've stimulated the patient, we've taken the response of the patient as well, how are we evaluating. Now during this response, it's very important for us to understand the concept of OHSS also, because it is something which can be predictive prior to the stimulation as well. During the stimulation also it can be prevented, and even after the pickup also it can be there. So you have to prevent it at every step. So the concept of hyper responders or PCOS is totally incomplete if we don't discuss the ovarian hyperstimulation syndrome. We define it as an serious complication that is associated with controlled ovarian stimulation during assisted reproductive technology. And basically what happens is there's a loss of control which was there in uncontrolled ovarian stimulation. That's why the name is controlled ovarian stimulation. If that control is lost, it leads to an exaggerated response of the ovaries ovarian response, which is not in the safe limits, and it leads to ovarian hyperstimulation syndrome. So it is of two types. It's an early onset OHSS and it's a late onset OHSS. So early onset, it appears 10 days after the HCG administration, and the late appears greater than or more than 10 days. So early onset is before 10 days. So after you administer HCG, so the first 10 days, if it happens, it's the early onset. And if it happens beyond that 10 days, it's after the oocyte retrieval, then it is definitely a late onset. Early onset is more common, but late onset is more dangerous. So that's a basic thing. And many times the early onset OHSS is very self-limiting if there is no pregnancy. And late onset is definitely more severe because it mostly happens when there is already an embryo implanted, and it is more severe at that time. So what are the basic ways to prevent OHSS? So first, we have to understand there's a way called as primary prevention. There's a way called as secondary prevention. So primary prevention is it has not arisen. We are preventing it at the nip. So we identify the risk factors. We use an antagonist protocol during the stimulation. We use, the gonadotropin dose in a step-up manner, and we give a trigger which is agonist versus an HCG. We use dopamine agonists also as an adjuvants. We can also use volume expanders, and also an ideal luteal phase support in the form of progesterone, not HCG. Okay. Secondary prevention. So secondary prevention means that during the stimulation of controlled of the PCOS women in IVF, during this COS protocol, there's an exaggerated response. So this has already happened. Now what to do? How to prevent the progression? So we can do coasting. This can happen only in a long agonist protocol. Freeze all in any of these cycles. We can cancel cycle, which is not actually done. And also we need to diagnose the early symptoms of the complications which are arising, and also treat the OHSS if it's there. How do we identify the risk factors? This is a very important diagram which totally covers everything. And what are the risk factors here? Past history of OHSS in a stimulation cycle. Patient is a polycystic ovarian morphology. She's young. She has a low BMI. She has high AFC. She has high AFC and she has a high AMS 3.56, which we gave as a cutoff, right? During the stimulation, what all we can have a predictive response from? The number of follicles at the time of trigger, if more than 19 or equal to 19 and and greater than equal to 11 mm, also is a predictive factor. Then serum estradiol levels beyond 3500 picogram per ml are again a predictive factor. The number of oocytes retrieved. So if they are more than equal to 19 on the day of oocyte retrieval, then also it's a suspecting factor. So these are the various factors where we can see that, yes, she can have a exaggerated response to stimulation. There is a fair evidence. These are the guidelines by the ASRM committee opinion for PCOS primarily and for prevention of OHSS. They have come up with a beautiful paper, beautiful committee opinion guidelines, which states how to prevent OHSS, because that's so vulnerable for a woman. There is fair evidence that PCOS, elevated AMHP values, peak estradiol levels, multifollicular development, and a high number of oocyte retrieved are associated with increased risk of OHSS. While the cut points require validation, AMH values 3.94, 3.4 nanogram per ml, AFC greater than 24, development of greater than 25 follicles, estradiol more than 35 picogram, 500 picogram per ml, or greater than 24 oocytes retrieved are particularly associated with the increased risk of OHSS. So this is a grade B, that is a moderate quality evidence they have. However, what they have stated here is quite high number. So greater than 24 oocytes, and development of follicles more than 25. But the recent guidelines on PCOS, which are studied in various papers, and they have assessed ASRM also, they have assessed the ASHRAE also, and they have come up with a cutoff being greater than equal to 19 follicles on the day of trigger, and for the number of oocytes retrieved is also greater than equal to 90. So they have decreased the cutoff. Prevention and treatment of moderate and severe ovarian hyperstimulation syndrome. There is a grade A evidence that the use of ovarian stimulation protocol has to be GnRH antagonist to prevent OHSS risk in these women undergoing IVF. And we have already discussed through the ASHRAE guidelines of 2019-2020 that the antagonist protocol is the ideal protocol in terms of safety as well as efficacy. Trigger, how a trigger can prevent OHSS. This is very important. We know that OHSS, the main culprit here is HCG. So the agonist which we are using trigger is agonist trigger, the GnRH agonist trigger in a antagonist cycle for preventing OHSS in a PCOS woman who's being stimulated. So how does it act basically? It causes they use the agonist trigger for ovulation trigger. It increases the granulosa cell expression and secretion of pigment epithelium derived factor, and this is inversely proportional to VEGF. So if this increases, the VEGF, which is the actual culprit again in HCG trigger, it falls. It also falls, and thus the risk of OHSS decreases. Okay. The luteolytic effect of the corpusculum and the lower estrogen concentration in GnRH agonist trigger also decreases the granulosa cell expression of VEGF compared to with HCG trigger. So this luteolytic effect also comes into play, and hence the estrogen concentrations, they fall. PEDF is an anti-angiogenic factor and may contribute to luteolysis by reducing the establishment of blood vessels. So this PEDF, other than lowering the VEGF, it also has an anti-angiogenic effect. Therefore, the blood vessels infiltration is reduced in the corpus luteum, and also this is again one of the reasons why there is low concentration of estrogens. So there's a strong recommendation by the ASHRAE guidelines for ovarian stimulation, controlled ovarian stimulation in IVF cycles, that GnRH agonist trigger is recommended for final oocyte maturation in women who are at risk of OHSS. That is basically women undergoing the PCOS women undergoing COS cycles. Cabergoline. Cabergoline, majority of us would know that it is also used as an adjunct to prevent OHSS. So how does it act? Basically, it decreases the phosphorylation of the VEGF receptors, that is number 2, and thus decreases the VEGF-induced vascular permeability and hence OHSS. It may also be responsible by increasing the PEDF levels and hence antagonize VEGF. So vascular endothelial growth factor is decreased again, and hence there is a decrease in the number of estradiol levels. And there is grade A evidence to support the fact that cabergoline can be used as an adjunct in women who are at risk of OHSS to prevent the risk of OHSS. It should be started at the time of HCG trigger. Now, what all basically is known about dopamine agonist till date is that there are various articles which state that it has best known effective regime in the form of 0.5 milligram daily, starting from the day of trigger for 8 days. That's the basic standard regime which is being followed to prevent OHSS. And even Cochrane has supported this data. A word about metformin again. We have already discussed before that there are studies that have supported its use to prevent OHSS, and how does that happen, and what is the mechanism for that in women undergoing ovarian stimulation for IVF by long agonist protocols. So this is valid only when you're using a GnRH agonist stimulation protocol for IVF for PCOS women undergoing IVF, not the antagonist protocol. So there's a good evidence that metformin decreases the risk of OHSS in PCOS women. A word about coasting. So coasting is basically a concept of withholding exogenous gonadotropins for 2 to 3 days and postponing the HCG trigger until the patient's estrogen level declines to a safer level. So coasting leads to a selective regression of a pool of immature follicles, thereby reducing the functioning granulosa cell mass available for luteinization and resulting in a decline in vasoactive substances involved in the pathogenesis of OHSS. Coasting has been shown to reduce the incidence of OHSS in high-risk patients. And even the Cochrane it has supported the studies which says that coasting can be done in patients who are undergoing GnRH agonist protocols for IVF stimulation. And there is a significant benefit of coasting that was seen in terms of whether in safety to prevent OHSS, moderate to severe OHSS, especially where it was compared to no coasting at all. The second question arises here is when to coast and for how long to coast, because those women, those doctors or those gynecologists which are still using the long agonist protocols in term and not the antagonist protocols because of the cost issues, probably for them, when to coast, when should we start coasting, and for how long, how many days, 2 to 3 days, or like more than 4 days can we coast. So there was a beautiful study that was published, and they had had seen that there were successful pregnancies even after using coasting protocols. So they had come up with this study in 2005, and they had seen that coasting should be done when the leading follicle reached 16 mm and the gonadotropin should be stopped and the agonist can be continued. You should keep on evaluating your serum estradiol levels, and once it reaches less than 3000 picogram per ml, you can give the HCG as a trigger. So they saw that the average day should not exceed beyond 2. It should be never beyond 2. It should be either 1 day coasting or a 2 day coasting. It should not be beyond 2. The ASHRAE guidelines for ovarian stimulation, they state that the GnRH agonist trigger should ideally be used for final oocyte maturation, which we already know. There's a strong recommendation, and they also have a journal practice point that it should always be preferred. The agonist trigger should be preferred in a PCOS woman with or without a freeze-all cycle over coasting. So आप coasting मत कीजिए, but आप definitely agonist trigger use कीजिए, or you freeze it or you don't freeze it, that is not an issue, but you should not do coasting because these are more safer and a better option which you have. Now coming to once the stimulation is over and we decide what to do next to prevent OHSS, or what do we do in these hyperresponder patients of PCOS, we freeze all. So freeze all, as just we read the guidelines for PCOS stimulation, the cryopreservation can prevent OSS. Obviously, if you are preserving the oocytes, you're not keeping the oocytes inside, the estradiol will fall drastically, and hence you're not doing a fresh transfer, you're not giving HCG. So definitely the risk of OHSS falls. So it's a very good way of preventing OHSS risk in PCOS women who are undergoing controlled ovarian stimulation. And there's an incidence of there's a low quality evidence by Cochrane that says that embryo freezing is helpful in preventing moderate to severe quality severe type of OHSS. And there is a freeze-all strategy that was presented. This article was presented by Grisinger et al. And he had used the freeze-all strategy in a multi-centric study wherein all these PCOS women who were triggered with agonist only and in an antagonist cycle, and they had shown that this was very effective in preventing the risk of OHSS. So they had reported there were only 3 cases of OHSS of moderate degree and only 1 case of OHSS of severe degree, which was seen in these patients. So that was a wonderful result without compromising the live birth rate and the clinical pregnancy rates in this woman. Even now, the ASHRAE guidelines, they strongly recommend that a freeze-all strategy should be followed to eliminate totally the risk of late onset OHSS, and definitely this high response risk factors could be identified beforehand prior to stimulation is started, as we just spoke about. So it is ideally recommended now to go ahead and freeze all the strategy. A word about the volume expanders, because it's something which is very often used in preventing OHSS. And you see that the patient has had an ovulation trigger, and then she has done the pickup, and on the day of pickup, we are giving her volume expanders, okay, if we see free fluid in the cavity. So this is in the form of human IV albumin, hydroxyethyl starch, or mannitol. However, there are no clear evidence which prove any of these is superior to the other or are inferior to the other. And there is very low quality of evidence that how it is helping or in the prevention of moderate to severe OHSS. Some of them say there's improvement, some of them say there's no improvement in OHSS. So there's a mixed study in literature that the use of the volume expanders for the prevention of ovarian hyperstimulation. Lastly, we are going to also have a word about the luteal phase support in PCOS women. Now, we know that there's probably a deficiency of progesterone in these women. There's a luteal phase defect that happens in PCOS women. So, how to take care of that? So, ASHRAE guidelines, as per the ovarian stimulation guidelines for the hyper responders, they say that the progesterone is highly recommended strongly for luteal phase support after IVF-XC, and there is no role of HCG. So HCG should not be used. This is a very important thing because it's already a predisposed condition for OHSS, ovarian hyperstimulation. And the dosing, which the general practice, practice points they have come up with is 50 milligram once daily. So understand here, many of us will have doubts how much to give subcutaneous, how much to give intramuscular, whether to give vaginal, whether to give oral. So what they say is oral or any other route like vaginal is equally efficacious. So none of them is superior to each other. You can use either 50 milligram of intramuscular preparation or 25 milligram of subcutaneous progesterone or a 90 milligram of daily vaginal progesterone gel or 200 milligram 3 times a day of micronized vaginal progesterone in oil capsules. So starting of the luteal phase progesterone for should be in the window between the evening of the day of oocyte retrieval and the day 3 of the post retrieval. This is also a general practice point that they have come up with, and they should be at least administered until the day of pregnancy test. So IVM, we many of us would have heard the term of in vitro maturation. And what is the role of IVM and what are the recommendations for IVM in patients undergoing PCOS stimulation cycles? Many times we have seen that in these patients we don't get good quality oocytes. We don't get, we get a number of egg retrieved are there, but the quality is very poor. So for those patients, we have a concept of in vitro maturation, which is subsequently being, still under research, and there are not much evidence on that. So the Cochrane, it says that both favorable maturation, fertilization, pregnancy and live birth rate, but also the pregnancy complications, including congenital anomalies, have been reported with IVM, which are similarly to those with conventional IVF or ICSI cycles. And there's no data to support the recommendations for clinical practice as of now. IVM may not be preferred as a first-line treatment for subfertile women with PCOS, and it might be appropriate to continue to offer conventional ART. So it's still not the preferred first-line treatment, and there are no actual data to support the recommendations for clinical practice till date. However, the 2018 guidelines which came up for PCOS in 2000 by the ASHRAE and the Monash University in collaboration with ASDM, they also said that there is the units which suffice expertise. In them, IVM, that is in vitro maturation, could be offered to achieve pregnancy and live birth rates approaching those of a standard IVF-ICSI treatment without the risk of OHSS. So what they say is basically, to prevent OHSS, one should not use IVM, but it could be offered in those centers which are actually suffice with the expertise, to offer a good pregnancy rate and to have a good live birth rate without the risk of OHSS for women with PCOS, where an embryo is generated and then we undergo and vitrified and thawed and transferred and subsequently cycled. So this is basically an evidence-based guideline. The ASHRAE, they have come up with ovarian stimulation 2020 research article with a clinical practice point that the IVM basically is defined as the maturation of in vitro of mature cumulus oocytes complexes collected from the antral follicles, both from stimulated and unstimulated cycles, but without the use of human gonadotropin trigger. And there's a clinical recommendation on that same what the ASHRAE had recommended before in 2019 in collaboration with other societies. Again in 2020 it has come up with the same thing, that IVM could be offered in the highly these highly expert centers wherein you can have a good pregnancy rate and a live birth rate without having the risk of OHSS. Laparoscopic ovarian drilling. So this is one slide which I put in the end. Why? Because we as gynecologists see patients who have PCOS and they might be undergoing the first line of treatment, then the second line of treatment, and then the third line of treatment. So what is the role of laparoscopic ovarian drilling? Should the big question comes here is, prior to IVF, should it be done? Now here I have like a few indications when we are doing it, like anovulatory resistant clomiphene citrate cycle patients, high LH and high AMH patients, exaggerated response to gonadotropin in previous cycles, and there is a need for other laparoscopic assessment of the pelvis, or there is a patient who thinks that they are non-compliant to follicular monitoring or hormonal assays, and they would be coming from far off place, and they would go ahead with laparoscopic ovarian drilling, and they could try at home then. Now, what is the need for doing a laparoscopic ovarian drilling prior to IVF? So, is there any need to do it? Ideally, there is no need to do an laparoscopic ovarian drilling prior to IVF, because in IVF we are going to take those follicles as in toto, and if we do it LOD prior to that, we are going to reduce the response. We are going to decrease the number, and this would be harmful for us in when we are taking number of follicles and making the number of embryos, and we decrease the chances of the patient for a cumulative pregnancy rate, I think so. But here my question, basically was that whether when a couple is coming to you, you don't know whether subsequently she's going to go into IVF or not. Ideally, screen the patient there and then, because there are particular indications for IVF which was discussed. If she's satisfying into that, rather than doing her like a step by ovulation induction, seeing an exaggerated response, or just seeing 3 times ovulation induction, she ovulated, then she cannot use gonadotropin. So just subjecting her to laparoscopic ovarian drilling and then letting her try again 3 months with an ovulation induction, which she's ovulating, so that time it was not needed. So you have to screen your patient there and then, that whether she needs actually laparoscopic ovarian drilling or she might undergo into IVF later on. And for that reason, we suggest that the gynecologist should refer for an opinion or for a counseling to a fertility specialist, because when sometimes it happens that these patients come to the fertility specialist, and that time unnecessarily laparoscopy with a drilling which is not even like a drilling of a protocol base, like a rule of 4 is not even followed. That time it is damaging for the the IVF specialist, because we have an AMH which says it is maybe probably 6, but the number of follicles what we see is less. We see it 8, or we see 6 on one side and 8, so it does not match. The AMH does not match the AFC. So that is a problem which the fertility specialist face, and that's why recommended or advised for the the practicing gynecologist to at least consult or to at least refer for a counseling session to the fertility specialist, so that they can know whether to go for a laparoscopic ovarian drilling, or this patient directly needs to go for an IVF. Okay. So we all know that the evidence-based guideline or the recommendation by the PCOS for the PCOS, that laparoscopic ovarian drilling could be considered as a second-line therapy for women who have not responded to clomiphene or they are resistant to clomiphene, right? And laparoscopic ovarian drilling could also be potentially offered as a first-line treatment if you have laparoscopy being done for another reason. So it can be offered as a first line, like suppose if she has suspected endometriosis also, or if she has pelvic inflammatory adhesions which you are suspecting. So in those reasons also you can take it as a first-line option. The summary points which we take home from this lecture are that IVF is basically the third line of management for infertility in PCOS, until and unless there's a adjoining factor like a male factor or a blockage of tubes that leads to directly it as a first line of management. Then AMH, age, BMI, AFC are best used predictors for controlled ovarian stimulation protocols in IVF. Antagonist protocol is the ideal protocol for IVF in PCOS to prevent OHSS. Follicle stimulating hormone is the gonadotropin of choice. Metformin could be used as an adjunct. However, it should be used in long agonist stimulation protocols only to prevent the risk of OHSS. Freeze all is the strategy nowadays for decreasing the risk of OHSS or totally eliminate the risk of OHSS. And lastly, IVM is basically in vitro maturation is or can be performed in expert centers to decrease the risk of OHSS and give improved implant live births by freeze all the FET cycles. Thank you.
Thank you very much, ma'am. It was a very wonderful class. You have nearly touched all the aspects of PCOS, right from its physiology, pathology, and you have also ventured into IVM and given us all the recent evidences related to it. Now, if anyone has any query, you can put it in the chat box so we can take it one by one. There is one question. In CC resistance, next step is gonadotropin or laparoscopic ovarian drilling.
See, the answer was there in the slides only, that you can definitely offer gonadotropins. However, if you think that there is another, associated abnormality in the form of maybe endometriosis or chronic pelvic pain, then probably you can go ahead with the tubal patency is not being performed. So then, though, the laparoscopic ovarian drilling can be combined with these, and you can proceed with laparoscopic ovarian drilling. However, if these features are not present, then you can try gonadotropin therapy as the second line management after CC resistance. But however, you should always discuss both the options with the patient, give the cost of the therapy to the patient, let the patient take a call, because each one of them are equally efficacious.
Okay, next one is, do you monitor estradiol and LH level in your entire protocols?
No, it's not recommended to do an estradiol or LH level monitoring until unless you see some discrepancy in your growth. Like if you see the dose being given and you see a discrepancy in the growth, if it's less than 1 mm, the size is not increasing after 2-3 days, then you have a discrepancy. Or if you are in a place where multiple people are doing the scans. So if multiple people, 3-4 people are doing the scan for the same patient, and you see that there is some error in the scan, or you see that the growth is not there, or even then also to be sure that E2 and LH would be a reliable met, because this is something which is a proper way that could be there. There could be no error in that, interpersonal error. So definitely in those cases, you should do it. And lastly, E2 can be done if you are thinking of a fresh cycle. E2 progesterone can be done at the time of, on the last day of the trigger when you're deciding, just in case if the patient is persistent on a fresh cycle. So I'm answering these all in its aspect of a polycystic ovarian syndrome only.
Next question is, do you increase or decrease dose of gonadotropin in POS in PCOS patient?
See, we can keep it static if the response is good. We can, ideally it should always be in a step up protocol. Like we should start with a smaller dose and then increase, and if it's okay, we can continue with that convention, because we gave the concept of a threshold and a this thing FSH window.
I think there are no more questions. Everything was very well elucidated in your slides. I would like to thank you again on behalf of IFS MP chapter. Thank you very much, ma'am.
Thank you IFS for giving this opportunity. And PCOS is a very close topic to, I mean, it's something which is very close to my heart, so I love teaching PCOS. Shall we wait for questions, or shall we stop the session?
I think there are some more questions now. What is your starting dose for PCOS in entire cycle?
See, there has to be those parameters which have to be seen. It can be either 225. Okay, however, if the wage of the woman is more than, so you cannot standardize it. Simple, you can't standardize. Keep it free. It can be either 225 or 300. It can be either of the two, depending upon the other parameters like age, DMI also, of DMI of the patient, her previous response to the stimulation cycles in the past. So it has to be individualized, but ideally, majority of times it is around 225. Someone has asked HMG or FSH, which one is better? So it is definitely FSH can be started in the beginning, because that time that there is a deficient number. The FSH is, the receptors are less sensitive, and you give it exogenously so that you can create a good FSH window. However, later on, you can add LH also. So there's no rigidity that you continue the whole cycle with FSH. You can definitely add HMG in the second half, like post your stimulation day 6 or 7, you can add LH also. And many times you have to add it even in women who are PCOS, but then they are of advanced age.
How do you how do you decide starting dose in PCOS patient based on what parameters? I think this question has been taken.
We answered it.
Yeah. And does decreasing the dose good idea?
See, if the response is good, you can even decrease it at the end. You will get to know once you're doing the scans. So if it is the response is going very well, keep the same dose. And in the end of the cycle, you can decrease because you're preventing the risk of OHSS, which is actually very minimal in an antagonist cycle. That is the most safer part of it. But yeah, you can decrease it at the end. So it's again an individualized approach. It is nothing that to be followed as a standard.
Do you use HMG for stimulation?
Yeah, I use HMG for stimulation, as I spoke before, that you can add HMG on day 6 or day 7. The LH has to be added probably for that point of time. We know that LH gets into picture at that stage when it is 10 mm size. So it's very good idea. Also, it decreases the cost of the therapy. It also gives equal benefit in terms of the side efficacy. Secondly, this is something which some patients would respond, some might not respond. So it has to be again seen over at least 2 days of therapy after a scan.
I think that's it. There are no more questions.
Okay.
Yeah, I think we can wrap up.
Okay. Thank you, IFS. Thank you so much, MP chapter
Thank
of
you
IFS,
again,
for
ma'am.
this
Thank you very
opportunity.
much.
Thank you, Achita.
Okay,
Okay, Ashita. Thank you.
Thank you.
Thank you. Thank you, the organizers also. Thank you, the Nivian Pharma team, for this academic event.
Pleasure, ma'am. Pleasure. Thank you.